picture this. You are sitting in the clinic reviewing the chart of a patient you diagnosed with pelvic inflammatory disease exactly 2 weeks ago.
Right, day 14.
Exactly.
Yeah.
She is sitting in the exam room right now. She has been on her standard 14-day course of antibiotics, and she is nearing the very end of that regimen.
And how is she feeling?
Well, her symptoms have vastly improved, but she still has a tiny bit of lingering pelvic discomfort.
That classic residual twinge.
Yes, that twinge. You are looking at her chart, thinking about how notoriously nasty and destructive these upper genital tract infections can be. The prescription pad is right there on the desk.
Or the electronic health record is already open.
Right. Do you stop the antibiotics at 14 days, or do you extend the prescription for another week, just to be safe?
It is, it's one of the most common, quietly agonizing moments in everyday clinical practice. You are staring at the screen, and that cautious inner voice starts whispering.
Because we have all been there.
We absolutely have. We have all had that patient who calls on day 13 saying they still feel something. Your instinct is to just hit the refill button so you can both sleep at night. It is a moment where clinical intuition and evidence-based practice just go head to head.
Okay, let's unpack this. Our mission today is to critically examine that specific 14-day cutoff for pelvic inflammatory disease. We need to figure out if longer antibiotic courses actually improve long-term outcomes for your patients.
Or if strictly holding the line is better.
Exactly, if adhering to the standard 2-week regimen is actually the superior clinical strategy. As someone who loves the psychology behind clinical decision-making, I find this everyday dilemma fascinating. Our default posture as clinicians is usually to fight aggressively.
Oh, the psychology of prescribing is a massive factor here. When you are faced with an infection that carries the risk of long-term devastating complications.
Like tubal factor infertility.
Right, infertility, ectopic pregnancy, chronic pelvic pain. The intuitive drive is to throw everything you have at it. It feels incredibly reasonable in the moment to assume that more treatment will definitively clear any lingering subclinical infection.
And help resolve those final annoying symptoms faster.
Precisely.
It is the ultimate play-it-safe mentality. We think, what is the harm of a few more days of doxycycline or metronidazole if it guarantees the pathogen is entirely eradicated?
We view the infection as a stubborn enemy.
Yes, and extending therapy feels like a cautious, protective way to ensure the patient's full recovery. But how does that deeply ingrained clinical instinct actually hold up when we look at the biological mechanisms and the hard data?
What's fascinating here is that it completely breaks down.
Really?
Completely.
Yes. When we measure the outcomes, both clinical cure and microbiologic cure, that well-intentioned assumption simply does not hold water.
So no added benefit at all. None. For uncomplicated or moderately severe cases of pelvic inflammatory disease, extending antibiotics past 14 days does not reduce the risk of recurrent infection.
Wow.
And it does not improve symptom resolution. Adding a third week of antibiotics provides zero measurable clinical benefit.
Let's get into the weeds on that, because saying the data says so is not enough to override a clinician's gut instinct. What is the actual biological or historical reason we landed on 14 days in the first place?
To understand the 14-day rule, we have to look at the life cycle of the pathogens we are typically targeting.
Especially intracellular obligates like Chlamydia trachomatis.
Exactly. Chlamydia has a unique biphasic developmental cycle. It alternates between the infectious elementary body and the metabolically active replicating reticulate body.
And how long does that cycle take?
That entire cycle takes about 48 to 72 hours.
So a 14-day course provides enough time to cover multiple replication cycles.
Precisely. You are keeping the drug concentrations above the minimum inhibitory concentration for enough consecutive life cycles to ensure the bacteria are eradicated when they are in their vulnerable replicating phase.
That makes sense from a pharmacokinetic standpoint.
Right. Once you hit that 14-day mark, the bacterial load has been knocked down so significantly that the patient's own mucosal immune system can easily clear whatever microscopic remnants are left.
But what about the long-term tissue damage? Because I imagine a lot of clinicians extend the prescription because they are terrified of the tubal scarring that leads to ectopic pregnancies.
Which is a valid fear.
Right. So does a longer course prevent that scarring?
We actually have robust data on this, most notably from the landmark PEACH trial.
The Pelvic Inflammatory Disease Evaluation and Clinical Health Study.
Yes. When they looked at the long-term outcomes, extending therapy didn't change the rates of secondary complications like ectopic pregnancy or infertility.
Why not? If you're giving more antibiotics, shouldn't the tissue heal better?
Because the mucosal healing process operates on its own timeline. The inflammation and the fibrin deposition that cause the scarring are already largely set in motion by the time the patient presents to your clinic.
Ah, so the cascade has already started.
Exactly. Throwing more antibiotics at the pelvic mucosa on day 15 doesn't speed up tissue repair or reverse the inflammatory cascade that has already happened.
That distinction between active infection and lingering inflammation seems crucial. A patient might still feel pelvic heaviness on day 14, but that doesn't mean bacteria are still actively replicating.
It is a classic clinical trap. Clinicians often confuse post-infectious hyperalgesia or sterile inflammation with active, uncontrolled infection.
The tissue is still angry, but the bacteria are gone.
Exactly.
If the bacteria are gone, then continuing to prescribe antibiotics isn't just useless, it actually becomes actively harmful. I want to talk about the hidden dangers of the more is better approach.
Because we often treat antibiotics as if they are a benign safety net.
Right, but they're not.
They are far from benign. When you extend a course of broad-spectrum antibiotics, especially the standard PID regimens that heavily disrupt the gut and vaginal flora, you are initiating a cascade of adverse events.
We are talking about severe gastrointestinal toxicity.
Yes, and a significantly increased risk of Clostridioides difficile infection, not to mention the profound destruction of the patient's healthy microbiome,
You are wiping out the lactobacilli in the vagina.
which paradoxically sets the patient up for recurrent bacterial vaginosis or severe vulvovaginal candidiasis.
And beyond the individual patient's suffering, there is the massive systemic issue of collateral selection pressure.
That is the broader public health crisis. Every extra day of unnecessary antibiotic exposure exerts selection pressure on the bystander flora in the patient's body,
You are actively promoting antibiotic resistance in the community.
exposing the patient to all of these risks for absolutely no added benefit.
It is all risk and zero reward. Which brings us to the core decision framework that needs to govern our daily practice.
The absolute default clinical posture must be the standard 14-day regimen.
For uncomplicated or moderately severe pelvic inflammatory disease, how should a clinician internalize this so they don't second-guess themselves every single time?
Think of the antibiotic regimen as the initial strike team and the patient's immune system as the occupying force.
I like that analogy.
After 14 days, the strike team's job is definitively done. The territory has been secured. If you lack confidence in that biological reality, you will constantly practice fear-based medicine.
But knowing the pharmacokinetics and pharmacodynamics heavily support stopping at 14 days.
That frees you from that anxiety. The 14-day mark is the exact threshold where maximum therapeutic benefit intersects with the lowest possible risk of iatrogenic harm.
So we have established the bedrock rule for the average patient. But medicine is never perfectly straightforward. When do we break this rule?
There are definitely exceptions.
What are the specific scenarios where deviating from 14 days is actually the right clinical call?
Well, the 14-day rule applies to uncomplicated or moderately severe disease. The first major exception where you throw that rule out is when clinical severity escalates.
Specifically regarding the physical architecture of the infection.
Right. The classic example is the presence of a tubo-ovarian abscess.
How does the pathophysiology of an abscess change the math on the treatment duration?
A tubo-ovarian abscess, or TOA, completely alters the pharmacokinetic reality. An abscess is essentially a thick, fibrinous capsule enclosing a highly acidic, hypoxic, and purulent environment.
Standard oral antibiotics penetrate that capsule very poorly.
Extremely poorly. Furthermore, the acidic environment inside the TOA can actually inactivate certain classes of antibiotics.
So the standard 14-day oral clock doesn't even start ticking in the same way.
It doesn't. You are no longer dealing with a simple mucosal infection. In these severe scenarios, the treatment usually requires prolonged inpatient intravenous antibiotics.
And often surgical or radiologic drainage.
Exactly. The duration of therapy has to be directly tailored to the clinical and radiologic resolution of that specific abscess, which frequently extends well beyond 2 weeks.
That makes perfect sense. What about the patient's response to the standard therapy?
That's another major factor.
Right. If a patient is on the standard 14-day outpatient regimen, but she calls you on day 10 and her fever is back and her pain is worsening, how do we handle that?
This requires vigilant clinical monitoring. You cannot just assume the infection is cured because she is taking the pills.
Because things could fail.
Absolutely. If a patient shows a poor clinical response, Mandatory clinical reassessment is required. You need to bring her back into the clinic, perform a thorough bimanual exam, perhaps repeat inflammatory markers or imaging.
Because at that point, you aren't just extending therapy blindly, you are investigating a clinical failure.
Exactly. You are looking for a missed TOA, an alternative diagnosis like appendicitis or an ovarian torsion or a highly resistant pathogen.
And if you find objective evidence of ongoing active PID,
Then, modifying the regimen or extending the antibiotics is fully warranted, but it is done based on data, not a hunch.
beyond the severity of the disease itself, I imagine there are crucial patient-specific factors that completely change our approach. Let's talk about pregnancy.
That changes everything.
Does the 14-day outpatient timeline apply if the patient is pregnant?
Absolutely not. Pregnant patients require an entirely different management strategy for several reasons. First, pregnant women were systematically excluded from the major randomized controlled trials that established the 14-day rule for outpatient therapy.
So the evidence base doesn't even apply to them.
Right. Second, the physiologic changes of pregnancy, like increased glomerular filtration rate and expanded plasma volume, alter drug clearance significantly.
And the stakes are infinitely higher because of the risk to the fetus.
The risk of maternal and fetal morbidity is astronomical. We are talking about chorioamnionitis, preterm labor, and fetal loss.
So a pregnant patient with PID requires immediate specialist input.
Usually involving obstetrics and gynecology. The standard of care shifts immediately to hospitalization and parenteral antibiotics, regardless of how mild the presentation might initially seem.
I want to pivot to another specific population, patients with compromised immune systems.
Another vital exception.
Let's say you are treating someone with poorly controlled HIV or a patient on biologic therapies for rheumatoid arthritis. Since they don't have that robust immune response to help clear the remaining bacteria, are we still stopping at day 14?
This goes back to our analogy of the strike team and the occupying force. In a healthy patient, the antibiotics knock the bacterial load down, and the patient's macrophages and T cells sweep up the rest.
But in an immunosuppressed patient, you do not have that reliable secondary sweep.
Precisely. Many of the antibiotics we use, like doxycycline, are bacteriostatic, not bactericidal. They stop the bacteria from replicating, but they rely on the immune system for the final kill.
So stopping at 14 days in a profoundly immunosuppressed patient might just result in the bacteria bouncing right back.
That is the risk. Those patients need highly individualized therapy. Extending the duration might be entirely appropriate for them to ensure full microbiologic clearance of the infection.
But again, this should be done in consultation with infectious disease specialists.
Absolutely.
Let's also talk about the practical reality of taking these medications. We know the regimens for this condition often involve drugs that are notoriously hard on the stomach. How do adherence and intolerance play into the decision to extend?
They play a massive role, and they dictate two completely opposite actions.
How so?
Well, if you have a patient with poor adherence, maybe she was throwing up the doxycycline for the first 3 days because of severe nausea, or she missed several doses.
So then the area under the curve for the drug concentration drops below the therapeutic threshold.
Right. In that scenario, you might need to adjust the timeline and extend the prescription to ensure she actually gets a full 14 days of effective systemic therapy.
But what if she's taking the medication perfectly and she is just experiencing severe, punishing side effects?
If the patient is experiencing sheer intolerance or severe adverse effects from the antibiotics, extending the therapy should be strictly avoided.
Because you're just adding more toxicity.
Exactly. You do not want to force a patient who is actively suffering from medication toxicity to endure another week of it just to satisfy an outdated clinical instinct. If she has completed the 14 days and the infection is clinically resolved, stop the drugs. Prevent further harm.
The final exception we need to cover is local resistance patterns, which is a rapidly evolving nightmare depending on where you practice. How does something like Mycoplasma genitalium change the 14-day calculus?
It changes everything. Local antibiotic resistance patterns in your specific community might force major adjustments in both the choice of the drug and its duration.
Because Mycoplasma genitalium, for example, lacks a cell wall.
Making beta-lactams useless.
Yeah.
And it is rapidly developing mutations in the 23S rRNA gene that confer high-level macrolide resistance.
So the standard azithromycin or doxycycline regimens might fail completely.
They frequently do. If you are practicing in an area with highly resistant strains, or if a resistance-guided assay comes back positive for those macrolide resistance mutations, your initial empiric therapy will likely be ineffective.
You may need to pivot to a sequenced regimen.
often involving moxifloxacin, and adjust the duration entirely based on the latest infectious disease guidelines for that specific highly resistant pathogen.
Okay, we have laid out the biological rationale for the 14-day rule, and we have detailed the very specific, evidence-backed exceptions. Let's spend some time busting some common clinical traps. What are the major pitfalls that should never drive the decision to extend therapy?
The biggest trap is the vague assumption we discussed at the beginning, the idea that longer is just inherently better.
You must actively fight that urge.
Never extend a prescription simply based on a hunch or an outdated sense of caution. If the patient does not meet the specific criteria for an exception,
Meaning no abscess, intact immune system, not pregnant.
exactly, then extending the dose is clinically inappropriate.
What about adjunctive therapies? Sometimes patients are utilizing other treatments alongside their primary antibiotics, like NSAIDs for pain or specific treatments for a concurrent yeast infection.
Clinicians should entirely avoid using adjunctive therapies as an excuse or justification to needlessly prolong the primary antibiotic course.
Just because a patient is receiving supplementary care for symptom management does not mean the actual antimicrobial window needs to stretch out for another week.
Right. The primary infection clearance operates on its own timeline. Treat the symptoms, but stop the antibiotics.
I think another major pitfall is overgeneralization of the data. It's so easy to read a study about severe inpatient cases and start applying it to mild outpatient cases.
Yes, and vice versa. Findings from uncomplicated cases must not be generalized to severe or complicated disease without making the necessary clinical adjustments.
You cannot look at the excellent success rates of 14-day therapy in mild outpatient cases and assume you can treat a massive tubo-ovarian abscess with the same light touch.
The datasets represent completely different pathophysiologic realities.
And when we are evaluating these patients, we have to be incredibly careful about how we interpret their symptoms at that 2-week mark. We touched on this earlier, but relying solely on symptom resolution over a telemedicine phone call seems incredibly dangerous.
It is a massive clinical safety issue. A patient might call and say her pelvic pain hasn't fully resolved. As we discussed, that pain could be residual post-infectious inflammation.
But it could also be a completely different issue.
Like an ovarian cyst, a newly formed abscess, or a failing antibiotic regimen due to resistance. You cannot differentiate those clinical realities over the phone.
So never blindly extend a prescription without an actual physical clinical reassessment.
Exactly.
Also, when clinicians are reviewing the literature to guide their broad decisions about treatment duration, how should they navigate the conflicting data out there? Because you can always find an observational study that seems to support longer treatment.
This is where understanding statistical bias is critical. Clinicians should avoid relying on purely observational data, which is heavily riddled with confounding by indication.
Explain how that confounding works in this specific context.
In an observational study, doctors naturally prescribe longer courses of antibiotics to patients who look sicker or have more severe baseline symptoms.
So when you analyze that data retroactively,
It might look like longer courses are associated with worse outcomes, or conversely, that patients who got longer courses eventually got better. But without a control group, you don't know the counterfactual.
you have to favor controlled, randomized comparisons instead, like the PEACH trial.
Relying on RCTs cuts through the noise and provides the clearest path to optimal patient care.
This has been an incredibly clarifying discussion. Let's distill everything we've unpacked today into one vital takeaway, the golden rule for your practice moving forward.
Keep it strictly to the science.
Yes. For women presenting with uncomplicated or moderately severe pelvic inflammatory disease, you must prescribe the standard 14-day antibiotic course. Make that your absolute bedrock default.
Only consider extending that therapy if clinical severity, like a tubo-ovarian abscess, a documented poor clinical response after a physical reassessment, or very specific patient factors explicitly justify the deviation.
Like pregnancy or immunosuppression.
It is about trusting the rigorous pharmacokinetic and trial data over our own clinical anxiety. We have to strike that perfect balance between definitively eradicating the disease and protecting the patient from the hidden, severe harms of unnecessary antimicrobial exposure.
This raises a really important question, though, and I want to leave you with a final provocative thought to mull over as you head back into the clinic.
What's that?
Given that minimizing antibiotic resistance is one of the primary driving reasons we strictly cap this PID treatment at 14 days today, how might the rapid evolution of new hyper-resistant STI strains in our local communities force the medical field to completely redraw this 14-day boundary in the near future?
It is a sobering thought for anyone in infectious disease or gynecology. As these pathogens continually adapt, mutate their binding sites, and change their armor, our timelines and our definition of standard empiric therapy may have to radically shift right along with them.
The 14-day rule is the gold standard right now.
But in the biological arms race against infectious disease, the finish line is always moving.